One of the chapters we're reading is the discussion of the difference between management and leadership. They're not the same, right?
Yeah, I can see that actually.
Bill, I'm just letting you know I've started the recording.
Yep. I saw the red light come on. I got a little flash. Okay, we're at 9:01. Sorry, I've been just getting my setup ready for those of you who weren't listening earlier. Apologies, I had a bit of a crisis this morning at work, and I'm just getting set up. Usually I'm ready to go, but I am ready now. So I'm going to call to order the meeting of SEOW. This is today, Tuesday, February 4th. Time is 9 o'clock. I have to click the people button here and say, is Robert with us? No. And is Dr. Laura with us?
Here.
Thank you. And I know I knew this at one time, but I'm not quite sure. I know Andrea's is with our team with OEB, but who became the official PEB team for this?
It's Greg, Andrea
Yep.
Foltz, and Kimberly Hendricks.
And Kimberly. Okay, so Greg, you on?
Greg's in Mexico. He
That's right.
may be able to join.
I remember he told me that. Right. I just as soon as you said it, it's like, oh yeah. Andrea? I
I'm
see you,
here.
Andrea. Yep, I see you. And Kimberly. Did we send Kimberly an invite?
Yeah,
I hope so.
I put her on our outgoing list. So
Okay, so we have one PEB member and two OEB members, which technically puts us right at the border. But maybe we should. I'm debating whether we have quorum or not with 3 out of 6. Do you have an opinion on that? Yeah, because 50 plus 1, so we're technically mathematically we're a no, right? Okay, so I'm going to skip item 2. Welcome everybody to the meeting, and we're going to hold off on the approval of the minutes, and hopefully Robert or Kimberly will join us.
I just had technical difficulties. I'm here.
Oh, Robert's here. Okay, so now we have it. Cool. Thanks, Robert. Okay, so let us say now, did the members present have a chance to look over last month's minutes? And Robert, you were here for that. Andrea, you were here for that. Anybody have any questions about last month's minutes?
No, make a motion to approve the minutes as written.
Okay. Andrea or Dr. Laura, you want to second that for me?
This is Andrea. I'll second.
Okay. We'll just go with a negative thing here. Is there anyone against approving the minutes? On the motion on the table is to approve the minutes as presented. Anybody against? Hearing no one. Anybody abstain? Hearing no one. That's a unanimous vote for. All right. So now we are off. Where's my agenda? Here we are. All right. That takes care of the first item. So now the second item, leadership discussion. So this is where we're talking to the team here. We have this new setup. We are missing 2 people. Primarily, PEB is only represented by Andrea. So I'm not sure we should elect a leader. I'm going to open the floor for discussion of the board members. I want to start by saying there's only, we have this meeting, which I'll run, and then there's March, April, May. There is a meeting in June, but it's kind of a wrap up and a look into the forward. But so my term will end here in just 3.5 months, 4 months. So I don't mind leading SEOW if there wants to be a co-chair for someone to get experience on who hasn't been on SEOW, or if you've been on SEOW, which Robert and Andrea, you have. If you want to take over the chair, I'm just as acceptable. I don't mind doing it. I actually enjoy it. But I want to open the floor for discussion amongst the board members. What do you think? Okay.
Well,
Um,
okay, so I'll say that, the OEB structure, the way the chair works is that we rotate amongst the different constituency groups. And I think, that model works pretty well. So now that we're joined, I think it'd be great if we could, rotate is it chair
Yeah,
of
so we-
CL, whatever that designation is,
So we could go back
between
and
PEB and
forth.
OEB.
Yeah, we can just go back and forth between PEB and OEB, like you just said. My question first is, should I just finish out this year and get somebody to join me as to come up to speed if you haven't been on CL leadership team? And I'll finish out the year as chair, and then that person starts we start, there would be a PEB. And in your recommendation, which I agree with, PEB would be a chair starting in July. And I'll finish out this year. Does that make sense? Is that okay? And or what's the suggestion? What's everybody think?
I think that's a good idea. Of course, I'm the only PEB person here, so I would definitely like my constituents to see. But I think that if you're, do your term, and then maybe, again, like you said, if one of the PEB members is interested to kind of maybe shadow you for the rest of the year, and then do it. But I'm also, so I'm good either way.
Yeah. Okay. I think it'll keep fluency. We kind of mapped out the CL, stuff we're going to do for over the next 3 months before we wrap it up in June for this year and start looking at the next year. So it's kind of well defined. It's not inflexible. We can change anything we want as board members, but we kind of know what we need to do. It's, we're focusing on women's health for sure. We're focusing on some other items that you'll see here coming up, and especially equity. So what about Robert and Dr. Laura? Robert, you okay if you want me to finish out this term and then we start with the new format?
Sounds like a good idea.
Dr. Laura, do you have a comment or an input?
Sounds good.
Okay. So with that said, by consensus, because we just went around the room, I'll finish out my term, but we'll pick a PEP member to join us at the leadership meeting, and then we'll decide in July. Well, you guys will decide in July who is going to be the chair. Right? Is that fair? Is that a plan? Okay, so by consensus, that's what we'll roll with. Because I'm already the chair, I'll just finish out this term. All right, I'm going to now lean on Glenn to say, Glenn, you as staff, do you have any issues with the discussion the board just had?
No.
Okay, then that's the plan. All right, so we'll wait to hear from Kimberly and Greg, Andrea, to see who you want to raise up, and whoever it is, we're happy to have you join and help input the planning for next year. Okay. All right, excellent. All right, that will take care of that item, and now we're definitely ahead of schedule, which is cool. And I do see the health equity work group update slides are up. And Dr. Schwang and Christy Ewing, are you available? We're early.
Hi, Bill. I think I'll open it up and then
Andrew.
pass it off to those two as we get
Okay.
going.
Okay.
Good morning,
let's roll.
everybody. All right, thanks, Bill. Good morning, everyone. I think I probably know most folks, but maybe not everyone, so I can introduce myself. My name's Andrew Hoffheimer. I'm a consultant to the PEB board. And I'll just kick us off here, walk us through these first few slides and get folks oriented to today's discussion before I hand it off to Dr. Twang and Christy from the Mercer team. Okay, I'll just spend a couple of moments here level setting, again, on the agenda for today's discussion. sort of at a high level, the purpose of these next few monthly SEOW meetings is really to support the carrier renewal process for both boards, specifically through evaluating the clinical components of the renewals and the associated health equity implications of those clinical components. And so this is really one of the key functions of SEOW. And so these clinical reviews, they're going to be occurring in these monthly meetings in SEOW, and will be largely the conversation will be based on the strength of the clinical evidence of these programs for consideration, as well as any, again, associated health equity implications related to those optional programs. So all that said, to sort of orient everyone to the fact that there are certain components of the renewal that really are not discussed in these meetings, most notably cost impact, as well as some other pieces of any sort of related considerations that might inform decisions that the broader boards will make. And so I just wanted to sort of provide that orientation that the focus really here is on the clinical components and the associated health equity implications of those optional programs. And so with that said, the first section for today's discussion is going to be around health equity. This portion is somewhat informational, and it is to talk about how the health equity work group is integrated into this process, supporting SEOW and the broader renewals. And so the health equity work group is a collaborative work group. There are members from both boards on it, OEB and PEB staff, as well as Mercer consultants. And so we'll talk a little bit about some of the tools that they have at their disposal, as well as other types of analyses that they do to help support what will ultimately be a recommendation from this group to each of the respective boards. Let's see here. And so we'll spend some time talking about that. And, you know, even though it's informational, please do jump in with any questions or comments as we're going through that section. Once we've gotten you oriented to how that piece will be incorporated, we'll shift a little bit and start talking about the specific clinical proposals that together we're going to be reviewing over these next few months for this renewal cycle. And so there are a few specific clinical components that we're going to be focusing on. Some of those components are going to be applicable to both boards. Some might be applicable to just one board or the other. And so there's different reasons that might be driving that. And so in some instances, there might be coverage in place with one board that's not in place with the other. In other instances, it might be driven by PEB's upcoming medical and pharmacy RFP. And so that RFP is influencing this renewal strategy for the 2026 plan year in a couple of ways, but most notably, the PEB board has decided not to implement any new subcontracted point solutions in 2026, given the RFP, which will have an effective date for the awarded bidder of 1/1/27. And so when we get to that section, we'll orient you to how we've indicated on those slides, you know, which board it's applicable for. And then in the third section, we're going to be discussing subcontracted point solutions that are in place today. And the intent here with this project is to really sort of bolster our vendor management strategy and bring a little bit more rigor in terms of how we're evaluating the performance of these subcontracted point solutions from a clinical outcomes perspective. And so when we get there, we'll spend some time getting grounded in, you know, what is the purpose of these point solutions? What does the sort of universe of point solutions look like today that are currently in place? And there are quite a few. And so with this renewal cycle, we're really focusing in on those behavioral health point solutions. Because as you'll see, there's a lot of point solutions in place today. And so this is an opportunity for us to really focus in on a specific area that we know is really a key area of interest for both boards, which is behavioral health. Quick housekeeping item. We are continuing to explore different formats for these meetings. We've had some discussions on how best to really facilitate discussion, make sure this isn't just a presentation where you know, we're sort of speaking to you. And so we have included some prompts throughout this presentation. And so that said, you know, at any point, please jump in with comments and questions. Again, this really is meant to be a discussion so that participants from both boards are really feeling as informed as possible to be able to make that recommendation to the broader boards. We want to jump to the next slide. I I don't have the participant list in front. Oh, Kimberly, I see you're on. Hi, Kimberly. Welcome. So this slide is just an acknowledgement for the PEB board members who are participating with us now. And so Andrew and Greg, you've both been with us for quite a while now. And we appreciate your ongoing commitment to this group, but wanted to give a special shout out to Kimberly. I'm glad you could make it. And thank you for agreeing to participate with us here. It means a lot. We know that, there's a time commitment that comes with participating in this work group. And so we're glad to have you with us, and again, thankful that for your willingness to help us out with what is a pretty important part of the renewal process. Greg is in Mexico, so he gets a pass. At least I hope he does. I hope he didn't call in for his sake, but maybe he did. And so let's jump ahead to the next slide. We've put together this perspective to try to highlight some of the similarities between the boards, since this is still sort of early stages for our joint partnership with the revised charter being approved in the last month or two. And so there are some pretty key similarities when it comes to high-level strategies in the form of core goals and core values for both boards. Which is great to see. These are sort of at a high level. These really inform decision-making processes that both boards go through, in particular through the renewal process where there's a lot of decisions to make. Obviously, the boards are also different in a lot of ways, and that's fine. But SEOW in this space is a great example of a joint project that is really going to benefit both boards and ultimately benefit members across the state. And so just wanted to reiterate that we're really excited that this is the direction that we're all collectively heading in together. And I'm looking forward to seeing how it shakes out over the next couple of months. Any comments or questions in these sort of first introductory slides? I'm not seeing any raised hands, but just want to pause and see if anyone wanted to offer up any comment.
I think although worded differently, we're all in the same core values, right? We're all pretty much looking for the same outcomes. It's nice to see. Anybody else from the board? I'm back and forth on to see the opposing, not the opposing. That's a bad phrase, especially in today's world. The others. Ollie, I see your hand is up.
Yeah, I would just add, both boards should be very proud of the work that they've done in this area. I think we were just talking as staff the other day about, the commitment, the priority that the both boards have put in this area to really ensure that they're working with policy decisions that do meet all members' needs, are inclusive and equitable across the board. And I don't think you see that necessarily across the board in OHA, and just wanted to call that out, that I think that both the PEB and OWEB board are seen as if not models, then something that other boards and commissions that the OHA administers can look to as far as tools and processes and even the work that's going on today. The discussion, I think, is very important for taking those next steps. Thanks.
Yeah, I really think it's important for everybody at the legislature to see that, OEB and PEB working together with separate groups, but still leading the way and the way insurance and healthcare should be provided, as a representative of the state of Oregon. So, yeah. Okay.
Well said. All right. Thank you. Yeah. Thanks for those comments. Yeah, go ahead, Bill.
No, I'm just saying, I don't see any other hands up. Let's move on.
Okay. All right. Sounds good. Thanks. And so with that sort of introduction out of the way, we're going to shift gears and I'm going to hand it off to my colleague, Christy Ewing, who's going to talk a little bit about the Health Equity Work Group and get you oriented to a couple of, again, the tools and different things that they do to support this broader process. And so, Christy, if you are on, I will hand it off to you.
I am. Thank you, Andrew. Such a great foundation for us to get started with our conversation today. And just wanted to say hi to everyone. Hope your Tuesday is starting well. And I think I've met everybody, but I feel like I should at least maybe just orient that I am on the Mercer side. I lead our health equity work group. And again, as Andrew shared, that is a collaborative effort with OHA staff. And then we have board members, 2 from PEB and 2 from OEB, but we have 1 open OEB position still. And so happy to be here today, and we'll talk through some health equity. So we wanted to really take a deeper dive. I know we've kind of talked a little bit previously about our health equity work that has kind of been going on behind the scenes. And so if we go to the next slide, we really have been working to take a little bit more of a formal approach of how our Health Equity Committee is doing our work, integrating with SEOW, and really the goal is to provide you all with information on the health equity considerations and to the broader board. And so what does this integration kind of look like with the SEOW process? You all are really identifying, what the focus areas are, for these clinical focus. And oftentimes they come from insights, like from Dr. Twang or the Mercer team or other things you all have heard, innovations in the market, also obviously board direction questions. And then one of the most important too is member feedback and input. And so once then we have an identified focus area or areas, as is mostly the case, then our health equity work group will track all of those and start to really determine how we are going to go about assessing the health equity considerations. And so we will do research on different areas. We will also, ask lots of questions of the carriers and the vendor partners to understand more. We also will pull on our Mercer expertise across our book of business. And oftentimes we know a lot about these different vendors or solutions that are in place, or different clinical initiatives with our clinical team. And then we also have a tool that's called the Health Equity Screening Tool. I'll be talking about this a little bit more in a few further slides. And so that's also another tool we have that will be part of our assessment and in building those considerations. And again, we're really working towards this considerations document that we developed last year in partnership with our board members that joined the Health Equity Work Group, really asking how can we best provide you with the health equity considerations in a way that is helpful, beneficial, gives you an overview, but also then pulls out the key areas to pay attention to. And so we do have that document that we work towards being able to provide. Once we've done all of that work, we also as a committee, we meet just about twice a month as a committee, and then we have our board members join us once a quarter. And so it's a very discussion-based, collaborative approach. Once we have then those considerations, then we will present those findings to all of you, along with the other clinical findings that are being presented. And so that way you have multiple avenues for information that is about a clinical initiative in order to really then make your recommendation on. And so then that's the last thing on this slide is then you all make your recommendation to each board with that health equity considerations being incorporated. If we go to the next slide, please. And so, as I said, one of the tools that we do rely on and use often is our health equity screening tool. And so this was developed several years ago, and it really was, as a way, obviously, to evaluate across all of the solutions in a very systematic way, the potential impact that policy and operational decisions can have on equity. It is designed to just be one of the tools in evaluating and making your recommendation, and then ultimately for the board's decision. Currently, as I said, we are using this tool regularly with applicable programs and resources. Some like a resource and actually like a structured program is one that fits really well with the health equity screening tool. We have found there's some things like maybe a benefit design change. Some of those don't necessarily fit the rigor that is involved with doing the health equity screening tool. But oftentimes, again, a program or a resource fits it very well. And we're able to really line out kind of what are the pros and cons of this solution. And again, being able to provide these considerations to all of you. One of the future thoughts about the tool is that, maybe there could be a scoring methodology added at some point. We don't have that in place right now. It is, though, very much a dynamic instrument that is always changing. We update it, as needed, but at least annually. And like one example I just wanted to share is that in January of last year, we refreshed the tool. It underwent like an accessibility review with our team here at Mercer, where we updated language on it to make sure that it was accessible and understandable. We also added definitions to all the terms that are in the tool as an additional sheet. So it can be used again very widely. We also clarified some questions to make them a little bit more objective. We added some questions about reading level. We're starting to incorporate some of the NCQA health equity standards. And then we also expanded the evidence-based definition to include consensus and community-based decision-making, because that's another area of the tool. And I'm going to get into that a little bit more in detail here. So just to give you an example of some of the refresh and enhancements that have been made in this last year. So if we move on to the next slide, this gives you a closer look at the tool and the areas that it encompasses. So to orient you to the screen, on the left-hand side, we have kind of these three key areas. So we have an organizational component, we have the health equity categories, and then we wanted to add these additional considerations. And so I'll go through each of these three categories separately. So under the organizational components, you can see here just more about the vendor, the partner that is bringing the solution forward and kind of their commitment to equity. Then in the health equity categories, we first look at the member experience. We look at access of the, is it accessible to urban and rural populations? What type of access points are there? We also look at safety. Is there integration with their primary care provider? What does that look like? Moving to the right, communication channels. So this is really an area that accessibility with the Web Content Accessibility Guidelines latest level of certification, which is 2.2. We look at that. Does this vendor have that certification in place? Have they made a commitment to that accessibility level? Languages is one that we also look at quite a bit. This is one I'm also going to address a little bit later, but we look at languages available in a variety of areas, right? So digital delivery, open enrollment, written and digital communications, and then also the delivery of the service and what languages are available. We also look at the communication that's available as far as what does the communication look like? What types of populations are being represented in that communication? So a really wide variety of different communication aspects. Health inequities, health equity. This is really looking at the data collection that's in place. Are they monitoring for inequities between different populations? Are they asking for gender in a way that is destigmatized? Social determinants of health, moving to the right. Also here we're looking at, does this vendor or program have in place a way to assess, identify, and help members navigate to the resources that could be helpful for them? Do they incorporate community-based referrals in their resources they provide? We also look at in health equity as far as what types of populations do they have special programs for different populations? Are there certain considerations or focus points? And then, as I shared, evidence-based, we did make that update. So now we use that term a little bit broad for evidence-based to be scientific, community, and consensus-based research. We look at outcomes. What are, are they using reliable outcome measurements? Are they using input and feedback from members and from the boards as part of that outcome measurement? And then we also look at alignment with Oregon healthcare transformation efforts and the board goals. And then lastly, you can see in the additional considerations categories, as part of the tool, we are looking at somewhat cost, trying to get some sense of that because our board members that are part of the health equity work group asked for as much as we could provide some sort of financial consideration on that document. So we do look at impact on premium costs and any limitations that might be present. And then also we look at implementation just to see, if there's any legal contracting considerations. Luckily, we have Brian and Ruby from the contracting team are part of the health equity committee, so we get that insight as well. And then we also want to be mindful of staff and what type of administrative needs would be in place. And so we look at those implementation considerations. I think we
Just
move
to
to the
validate,
next. Oh,
this is a tool for evaluating and maybe scoring people that the two boards contract with. Basically, we're looking at this is a tool for evaluating any contractor that or people we have contracts with for providing service. That's the way I see it. But is that the way you're looking at it?
yeah, I think that's exactly right, Bill. And this probably makes it a little bit easier to give you some ideas like this. So these 4 were from last year, just to give some examples of the programs that we ran through the tool and provided those health equity considerations. So these all came up last year as part of the clinical renewal process. Our work group did the considerations document, and then that was weaved into the recommendations and then ultimately for the boards to make their decisions. And I think on the next slide, we have a question yeah. So kind of to Bill, I think what you were asking about is, curious on feedback or thoughts from the SEOW group. Are there other ways you see, or do you, certain ways that you see integrating concepts from the health equity tool into your work?
This is open discussion with the board, but let me chime in a little bit because I do a lot of service in this kind of area. First, I want to say we all know what's happening at the federal government right now, and any kind of wordsmithing can be done in a good way that maintains our values. I'll leave it at that. You can all figure out the rest of that. Now, I also would like to propose a second concept. So this is really good for sitting there and understanding, okay, this is a vendor. How does this vendor respond? And how do we understand this vendor's commitment to providing healthcare in an equitable fashion? Also, I want to bring up that we have some things that we want to do in SEOW, especially when we're looking at issues around coverage, that we always want to ask ourselves the question of whose voice are we hearing in this concept, and also to ask ourselves whose voice are we not hearing. And by that I mean we're not ignoring them. I'm just saying who's not being helped by this, and that is a list. I mean, it's not a problem to have parts of that list, right? We just need to recognize it and say, okay, so if this policy is around people who live close to the border and have to cross state lines, then you just say, okay, everybody who lives in the corridor or in an urban area doesn't have this problem, right? But that's something that we always have to look at, is whose voice and which group are we addressing in such a way that I say to our kids, when we're teaching them marketing, if you come and tell me that the target market is women, you get a D for effort, right? Your what you're working on has a focus, and you need to acknowledge who that focus is, right? And then who's not in that focus, right? And then especially who's not, who has an issue that's not being helped here, right? So that we just ask ourselves these questions when we're talking about things that are being like affected by the 3.4% cap, so that it's always pointed out that, hey, here's what the cap is costing, some of our members. We're helping these, but not helping those. And that's part of the equity thing that we do in school districts, where we just say, okay, which student population are we helping here, and which student population's voice is not being heard. So that's kind of a detailed kind of a thing, but that's just when we're talking about stuff like drug coverage, things of that nature, or things that we charge extra for, things like that. How are we helping, and whose voice is not in the room right now, right? I know that's a topic that kind of gets sensitive because people like to avoid the negatives, but sometimes putting the negatives down and saying this is when you go to legislator, this is like, it's documented. This is what your limitations are preventing us from doing. So I throw that down for discussion with the rest of the members. Please unmute, and what do you think?
Well,
and staff as well, right?
This is Robert. I am a true believer in applying an equity filter, especially with vendors incoming and evaluating the existing ones. I guess I'm going to answer the rest of the question with another question is, do we need to apply the same equity filter when dealing with Moda and Kaiser, or do they already have their own equity filters in place?
That's a good point. And Providence, because I'll throw this down to,
Sorry.
we just start thinking about this in the bigger light, but Providence is there too.
That's right. Sorry about that.
Providence being in the news for for reasons, right? But yeah, and how should we be looking at that? Not Providence situation, but just how do we look at our primary vendors in this way as well? I know we do a lot with our primary vendors when we're always asking them, what languages are you communicating in? How are you reaching out to the areas that are most affected by access and social determinants of health? But just to make sure that we have that well in our forms. And I see that in the tools for evaluating vendors. This is a nice way of looking at it. I'm not sure if this tool is just a consideration form or a rubric, which is another question I have.
That's a great, I guess I wanted to, Robert, for your question, that's a great, so we did for the carriers, we did several years ago, a plan design review that basically went through and showed the opportunities and areas of strengths that the carriers had in similar categories to the health equity screening tool. It was a much more in-depth undertaking just because of the breadth of services that the carriers offer, and the fact, I will say, one of the differences with the carriers, and this is just with language accessibility, is that there are federal laws in place as far as translation services being available and some of those. And I will also say that carriers have been good partners with the communications component for open enrollment of the materials that are specifically for the carriers and the services they provide. And we have been monitoring that on an ongoing basis since that deeper dive was done with the carriers. I do think there's an opportunity for that possibly to be refreshed with some of the latest standards and learnings that we've had over the past couple years. I was curious if
others.
Oh, go ahead.
And anybody else have a chime in comment here? No.
I was just, Bill, going to respond to your question around, is the intent for this to be a considerations versus a rubric? And if I'm understanding your question correctly, it's not intended to be like a go, no go type of
Mhm.
tool where it's like you either pass or you don't. Oftentimes whatever's being evaluated is very nuanced from an equity perspective. And Christy, jump in here if I'm misspeaking, but the
No.
intent is really to just call forward those considerations so that they can inform the decision that's made.
Understood.
You're spot on, Andrew. That is very much, it is a considerations, not a decision-making tool.
Okay.
All right.
Yeah. Dr. Laura?
Hi, good morning. So I see like we have some examples there that this tool was applied. Do we have some data if working or not, and where we need to work better to can improve, or is too new to have some data to know exactly what is going on when we apply this tool?
We have, I will say that, yes, we have some after the fact information. In some ways, this is what our vendor management project that we're going to talk about later is going to be uncovering in some regards. We do have a health equity focus area that we have as part of that project, and many of the aspects of the tool are being brought forward into that project. So we will have that opportunity. I think a lot of times we're applying the health equity tool when a program or a resource is being proposed. And so we kind of can look at it from what we know about that vendor or what they're telling us about their services. And that's where we develop that initial consideration. We can also use, again, like our experience maybe with the vendor in the marketplace to also inform some of that, but it would be later after the fact. And again, through probably our vendor performance assessments that we're doing, that we'll be able to actually show some data as to, are they really delivering on what they said they did in terms of equity?
I see. And then I have a second question regarding the consensus-based evidence. I don't know if you can expand a little more about that, how that is working when you apply that methodology. Thank you.
Thanks, Dr. Laura. So I'm going to this is an area of new, right? There's not a whole lot of consensus-based research that we can find in the literature. We felt this was really important to include in the tool. And at the same time, in talking about it, and I will say Dr. Dawn Mottner from the PEB board, we met separately with her just to also get her input and learnings. It's an area of great opportunity to learn more of how to incorporate consensus-based. And I think our initial first part of including that is in our research is that if we come across a consensus-based literature or something about a program or a resource, we are going to pull that in and make sure that that is incorporated into the considerations versus only relying on scientific evidence that might have only been done on certain populations and excluded people. But definitely still, we're in the initial stages of incorporating consensus-based evidence in the tool.
Thank you.
Yeah. And open to also suggestions if you have other areas that we can, improvement areas in that regards or a special expertise or passion about that. Glenn?
Yeah, I just wanted to kind of reiterate, but point out that the idea for integrating the health equity work group is within that kind of time frame context of, as Christy was pointing out, during renewals, we will get proposals from the carriers. on different programs and was to work closely with the health equity work group so that they could use their expertise, use as been pointed out the tool, and then provide those considerations that SEOW then would use when making that final recommendation. Now, Mercer also does do at the end of, right prior to renewal, they will come forth with certain, say, clinical ideas of areas that need to be addressed. And Christy, I believe that health equity is taken into account with that. But it's not kind of an overall look at the, what is the health equity of all our benefits and then saying, where do we need to really improve? It's more looking at, based on the ideas that have come forth, what is the health equity considerations that SEOW needs to be taken into account?
Yes, Glenn, I think the application of the tool is typically for things coming forward that are being proposed as part of the renewal. Our health equity committee work is definitely broader than that, as you said too. It does encompass kind of current benefits and how can we push the carriers to do better, to continue to improve on equity, and again, responding to board questions, board direction, SEOW questions and direction, and then also very much member feedback input is also a huge area that we get our work from and are focused on. All right, just want to make sure. Any other questions or comments? I don't want to rush. I love having conversation and questions, discussion.
Let's go ahead and press on.
Okay. Awesome. So so these are detailed. I'm not going to go through this in detail, but I just wanted to share with everyone kind of what one of these considerations documents look like. Typically, or I should say sometimes these aren't shared in their full entirety. We might be incorporating some of the clinical considerations into the clinical conversation, but this is what our team is developing. So a high level overview of what the program is, the services provided, all of that. And then if we move to the next slide, so this one was Mighty Health that we did during the last renewal cycle. Our summary provided, again, what was the member impact? Kind of to orient why is the carrier bringing this program forward? It might be something that was asked for in the renewal, or it might be a gap that's needed, and how would it impact members? We then also, through our health equity screening tool, come up with these top 3 concerns. As you can see here with Mighty, at the time of doing this, the app was currently only in English, but they told us that Spanish was on the 6-month roadmap and other languages were anticipated in 1 year. We also called out for Mighty that it really is designed for people over the ages of 50, and so wanted to put that in context. That's not that it only can be used by people over that age, but a lot of their communications and the face of the program typically is people over the age of 50. The other thing we wanted to report on is when we asked about collection of data and monitoring for inequities, that real DSOG reporting was not current capability, but they said that they could collect that information if it was included on the eligibility file. And then we did provide the cost impact at that point in time when we were doing the health equity screening tool. I'll just say I think this cost impact changed as we get further in the renewal process, but that's at the time we did it, that's what the cost impact was. And then if we move to the next slide, One thing we wanted to also just bring up today and to get your input and feedback on is that, it has come that minimum language standards. As I shared, the carriers have done a really good job for open enrollment information for their offerings. However, we do find that when we do the health equity screening tool, that there is some limits to the languages that are offered with some of these solutions and vendors. So just to orient, common languages in Oregon, Spanish is the second most common language. There's about 126,000 individuals in Oregon, and then Vietnamese, Chinese, Russian, and Korean. Our current state, as I said, the carrier partners do offer English and Spanish versions of open enrollment materials, websites, and other member communications. However, many of our subcontracted vendors only offer their materials in English and do not have Spanish on the roadmap. We'd really like to work towards a future state where we have minimum language standards that are adopted by PEB and OEB, that is English and Spanish. And again, this is in a variety of areas as far as member outreach, engagement materials, communication materials, also verbal communications, and then also obviously in service delivery of that product or resource. And then having a roadmap for some of these additional languages. And so I think our next slide is just asking you all for your input. What do you think about establishing some minimum language standards for our materials and the services that are provided to PEB and OEB members?
Board members, I'm all for it, but I can't define what that would be just yet.
I agree. I was trying to figure out what. I don't know enough to probably give you something from me.
I agree. I think it is. I'm not knowledgeable enough either, but I do think that part of it is the geography of the state. That you're going to find maybe some languages in some places more than others, and I don't know how that would be represented. So.
But I mean, this is kind of funny to say. I'm going to say something that's not copacetic, but I don't know where the bar should be set at for demanding that, okay, you have to support this language, but I know that Spanish is over that bar, right? So Spanish at a minimum, no question about it, and that's everywhere in the state, right? So that's where my thinking is. I stop there, right?
I'm
Yes.
I'm sorry, Christy. I'm kind of surprised that it's not even in some roadmaps the idea to incorporate another language, at least Spanish. So I think this is a good proposal. I don't have question. It's just I'm really happy this is going to happen eventually.
Thank you. So I guess so what I'm hearing too is that, so it sounds like maybe Spanish as the English Spanish as a minimum standard seems like that kind of can be something maybe where we can start.
That's
but
right.
then it sounds like providing more information, just more details, and having further discussions on going somewhere from there.
So Robert, so maybe part of it is what we can determine what's the threshold percentage wise that would trigger us saying, yes, we need another language adaptation.
Yeah,
that's the bar that I was talking about. I'm not sure how to set that bar. I have a comment that says, I don't ever want to see an adult in need of health care relying on a child to translate for them. That is just the worst case condition. And that, that's that hardly ever comes out in the positive. But I don't know how to define that, right? So, but that's kind of where my head is at. That's what we absolutely don't want to see happen, right? Uh, a 10-year-old translating for their parent who's in a medical need is not good,
Mhm.
right?
So,
And
as an immigrant and English my third language, I think just having that diversity, equity, and inclusion lens is really crucial here, regardless the threshold. And sometimes we are gonna rely on data, but at the same time, like you Bills mentioned, we don't want those cases happen. So sometimes data is not there, or sometimes it's really minimal. But then for the inclusion, I think at least we need to have Spanish and then figure out if we're gonna grow more a language or not. That will be my feedback. Thank you.
So let's incorporate this into a future concept of how to do metrics on something like this, but and start with just English Spanish as kind of a critical requirement. Is that fair for everybody? I see head nods. Okay.
Yes.
Okay. Does that help you, Christy?
That is great. And one thing I just also want to just clarify, and I know this will come into our future conversations, is that there are, there are federal regulations as far as providing translation services within our carrier medical programs. So I think we can bring that in, but I just wanted to clarify that as well, is that most of the services being provided that are not in Spanish are through vendor partner programs that the carriers contract with, because there are these federal regulations for offering translation services, like within a primary care office.
Yeah, and I want to come back with a note regarding that, Christy. So
Mhm.
even the federal law is there. Healthcare providers, some in general in Oregon, we have a lot of education to do because they don't really know. And then the only suffering here is going to be the member. So that's another topic, but just to create awareness
Mhm.
about this topic.
Yeah, thanks, Dr. Laura.
Or everybody has to have a C3PO that speaks a million languages that can translate in the office, right?
Well, language
Okay.
lines are very difficult to use. I've been in a clinic that we had to do lots of education around how to use them.
Yeah.
Yeah.
Okay.
All right. Thank you.
All right. I think we're right on time going into clinical proposals. Double checking that health group update. Oh, sorry. Oh no, this is part of OEB medical dental plans preliminary proposal. Okay, so um, we're agenda calls for a short break. Um, I know this proposal discussion is important and we'll have a lot of discussions. Uh, can we do a 10-minute break, or is that okay for everybody instead of a 15? All right, so let's start this one at 10:10. Robert, are you up in Portland?
Yeah, I'm in Portland, but
Snow on the ground?
no, nothing. Well, at least
Nothing?
I'm in Beaverton right now, actually, and there's nothing.
Okay. Yeah,
Although
same
I
here.
don't have a window right now, so if it's changed in the past 30 minutes, I don't know.
Probably not. The sun just came out here. We got ice. You know, the blades of grass are frozen, but outside of that, there's nothing. Right.
Hey, Bill,
I think
we're
the
still
coastal.
meeting in.
What?
Sorry, Bill. We're meeting in person, right, for the second part, the board meeting, the OEP.
No.
Okay.
No.
Okay. All right. Good. Just double check.
Did I miss something? Hold on, maybe I'm wrong.
I think we agreed
No.
April.
Yeah.
Oh, April. Okay.
Yeah, not
Yeah,
till
for
April.
the final review of the proposals.
Thank you, Bill.
Yeah. Well, you had me scared there for a second. I'm like, oh shit, I gotta jump. Oops, I shouldn't have said that. Got to jump in the truck. Right. I think we're rolling up here on 10 after. Where is my slides here? Okay. Kirsten, are you leading this one?
No, Bill, I will.
Hi, Bill.
I'll
Yeah,
jump.
thanks, Ethan.
All right. Excellent.
Obviously, everybody chime in.
Yeah, I think we're 1, 2, 3, 4. I see. Yep. Let's go ahead and get started.
Great. Thank you, Bill. Good morning, everybody. We are going to proceed with the next section here. And next slide. So as we go into the clinical proposals discussed here, we would like everyone to sort of keep in mind and ask questions concerning anything else that you feel you want to know as we head towards making a recommendation to the board scheduled for next month. So that's the ask, but again, feel free to chime in and ask for clarification. Next slide. So the 3 clinical topics that are here are part of the renewal process, and they are aligned with our respective board goals, and is a sort of a continuation on our efforts to ensure that the clinical programs are in alignment. The 3 that will be on the table here are women's health, specifically the fertility and menopause support as one section. Followed by one on skin cancer screening as part of our efforts to optimize and improve our cancer prevention. And the last one is site of care, aligned with efficiency and affordability of care. So let's kind of dive into the first section, which is on fertility and menopause. Next slide. So just to frame the conversation of, obviously this is probably no surprise why the focus on women's health is important for OEB and PEB at the entities and agencies that are being supported. Some stats and figures here. We have 190 women within our two respective programs, accounting for 8% of all women in the Oregon state. And the breakout as are a higher percentage of women in both OEB and PEB. So the proposed area of focus is around pre-pregnancy and fertility support as one kind of benefit area, and the other one is menopause that we'll dive into. Next slide. And just further breakout to put some context, right? So obviously, women's health spans a continuum defined through roughly age-based needs for health and health benefits. And we've quantified sort of how that distribution looks within the OEB population as well as PEB. I think the ratios are pretty consistent across both, but obviously the absolute numbers are slightly different. So just for point of reference, obviously, these are loosely defined, so bear that in mind, but we have sort of age 18 to 35, 36 to 45 as the maternal age range. So individuals there potentially would be interested in the fertility benefit. And then we have sort of the perimenopausal and menopausal sort of age range as defined clinically for points of reference. So thoughts in terms of the figures, percentage and absolute numbers, no surprise.
Open to board members. I was aware, but I cheat because I'm in the data hungry category. So
for at least the website, I assume those percentages are still skewing older than the benchmark. Is that correct?
So if you can go back to the slide, yes, at least between OEB and PEB, we see a higher percentage slightly in the age 46 and older, or the perimenopausal and menopausal context for this discussion here, yes. In terms of benchmark compared to overall national, I don't have that stats handy. But obviously the slope and the peak is typically what we see population-wise. But the actual percentage, I think, I don't have a specific point of reference right now.
anybody else? All right, let's roll this data into action.
Okay. So using this wheel as sort of the full picture around women's health and well-being as sort of a placemat for context, the right side lists from a plan perspective, the various areas where we can consider ensuring that the benefits as defined and available support women's health and healthcare needs broadly. So areas include sort of inclusive insurance programs with various things kind of itemized below as examples, digital health solutions and what's provided under that umbrella, skipping the next two to flexible working leave policies, obviously within the entities and agencies and how they're wanting to support that, and then manager and peer training as well are things that matter and have an impact on women's health and their health journey. The two that are being highlighted here are what we're going to talk about. So the first one on the agenda will be the family planning benefits around specifically fertility. And then the menopause support is to think about how we can specifically have customized and personalized set of benefits and capabilities for menopause, spanning communication, education, and obviously, ideally, community, workplace, peer-to-peer, and virtual support. Next slide. So to level set across our OEB and PEB plan benefits, this is the current state landscape and which ones are being considered. So let's start with, as a category, fertility, the left column. So for PEB, there is already a set of benefits in place through each of the carriers. Kaiser is their own program and offering. MODA is through a partnership with KindBody, and then Providence is through Progeny. For fertility, what's on the table as part of this renewal cycle, what's being considered is MODA offering the KindBody parallel to what PEB has, and then Kaiser similarly parallel to what currently is in place at PEB. On the menopause support, both are sort of for consideration, and it is through partnerships for Providence and MODA across both PEB and OEB. Then Kaiser has made proposals within their own delivery system. So are there questions about the current coverage and what's being considered specifically for OEB, which is both, and then menopause specifically for PEB?
I'll chime in here. I have one comment is I'm kind of surprised that it's the same contractor for both categories. That I was not expected when I looked at the slides that popped. But my other question is just your general statement on the healthcare and medical studies of menopause. I mean, a long time ago, we talked about hormone replacement and all the positives and negatives and blah, 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 but not hearing anything for a long time. Are we behind, or does the medical world put a lot of effort into this or not?
I would classify that it is probably insufficient effort and not proportionate to the representation of the population. So obviously the needs and experiences are sometimes uniform across both genders as we age, but there are very unique needs that have an overlay due to just the different physiology unique to women. So we can speak broadly that yes, cardiovascular risk increases as we age. But medically, I would say that there's different things that we need to consider and different approaches to care that would be specific to women. And we are behind, I would say, comparatively speaking, in terms of the formal research, as well as raw clinical understanding at the point of care and delivery. So yes, we know as physicians what perimenopause and menopausal means, but I would say collectively as a profession, we are probably not as well versed, not efficiently and sufficiently trained because the research is behind and hence the experience of members correspond.
Thanks.
Sorry for the long explanation.
But that's what I was expecting. I just wanted to confirm that it seems like something that should get a lot of attention, but doesn't.
Yes.
Right.
So how that should translate to experience, sorry. Yes, Andrea, go ahead.
I was just going to say, kind of something that I notice is that when I go to women's doctor, I'll see, 18 pamphlets for, birth and things like that. And you'll see one pamphlet for menopause. And so, yeah, I would say just from the experience of, and a lot of the women that I talk to, that it's definitely not looked at enough.
Now, I was just going to comment, it's more than just symptom management. Just again, for each of the age-related risk factors, there's just different needs for consideration and different treatment choices and options, whether it's heart disease, osteoporosis, and other things like that. Other thoughts or questions?
Anybody else? I was just trying to reminisce that of all the commercials that we're bombarded with on TV, the only one I can remember about this category is something about a hot flash to a not flash. but that was the only one I ever saw involving this category compared to ED and everything else we get bombarded with, right?
Yeah. Okay, let's kind of proceed to the next one and take a look at one of the vendor partners providing. So now we're going to just focus in on the fertility benefit. Again, there's a key to the top right corner. So what is being reviewed here is already available in place via PEB, and it's for OEB consideration, and it's via our kind body partner, carrier partner. So 4 sort of categories to talk through. I'm happy to go in as deep as necessary, but from a benefit design, things to consider is how we structure the coverage, whether it's a cycle-based model or a lifetime dollar limit model. And what's being proposed is obviously the kind body 360. That's their branded program name. And from a clinical process, they deliver and provide care through their own clinics and provider network. And so they're the ones actually hands-on and directing the fertility treatment and care. Obviously, they have an integrated electronic health record to support their protocols and approach to care. So there's some level of evidence-based standardization of approach and the ability to report on quality and outcomes. Potentially formulary difference to consider, which may or may not impact and create what we call member noise because of prior expectations or preferences, potentially. These are potential. Network and quality access issues don't have any concerns. They have decent coverage and representation for different race and ethnicity subgroups. And other thing to highlight, member experience, very respectable NPS score from that they're reporting. Christy, any other highlights to comment here or point out?
I don't at this time. I know last year we did do a health equity considerations of kind body, so we can follow up and as we come to the decision making as we're moving through this process, incorporate that. We are also in the middle of refreshing that, so we'll have more to share from an equity perspective.
Great, thank you. Next slide. So as we look at what is being considered for OEB, obviously we have a model for MODA with kind body, and then Kaiser is their integrated model through their network of providers. The benefit coverage, what is being considered is ART is called artificial reproductive technology. So basically a fertility assistance, and it will be inclusive of elective as well as iatrogenic or basically medically related or treatment related causes of fertility issues, inclusive of preservation of eggs and sperms with storage up to a year. So that's sort of the single summary of the benefit coverage. And what will need to be factored in the consideration is, again, the structure of it, whether it's a dollar limit defined as a lifetime max or a cycle-based limit. The strategy, and this is mirrored and will likely suggest emulating, following the path that PEB has approached this, which is, getting the coverage in place and then growing that out over time to be more inclusive, more robust as a benefit coverage limit. But I think obviously there's considerations to factor in, such as cost to the current cycle and all those things to weigh in. But these are the 2 dimensions to keep in mind: is the structure of the coverage max, and then the strategy in terms of how much now versus later over time. And there are pros and cons that we listed below, just so for awareness of how it, there are pros and cons for a dollar lifetime max, both at a plan level and potentially at an individual level. And it is around the ease, clarity of kind of how much is available for the individual, but also how much is the upper limit of cost at the plan level. Cycle-based lifetime maximum have the benefit of tying it to the treatment cycles of each fertility attempt. So it's a bit more robust, a bit more flexible because it's everyone's approach and clinical journey will be potentially different. And this kind of aligns with the medical treatment cycle for infertility treatment.
So for OEB, is this as an option in our first round renewal letter?
Yes, they each of the carriers proposed the benefit coverage is defined, and then the variables for consideration are listed there.
Are in there. Okay, so we'll see this. All right.
Thoughts on the different benefit options being considered for OEB?
How long has PEB been doing Kindbody?
As of 1/1/25.
Oh, so it's fresh.
It's new. Yep. Mm-hmm.
Okay, so not much experience on how they're rolling. OEB has IV in vitro and things covered. Is that just covered through the primary care physician, or do we have a contractor for that?
Christy, we had talked about that. It's through the providers currently, correct?
Okay.
Yeah, I believe
Yeah,
they're
that's
just
correct.
Yes, thank you. Mhm.
So this would be kind of bringing that all with additional benefits under a contract service kind of a thing, a point solution.
And a more inclusive benefit by opening it up to that artificial reproductive technology.
Understood. Yeah, so I said by the added benefits, but also it would put it into this contract. Glenn, I see your hand up.
This is kind of a question to Mercer. My understanding is that IVF is not currently covered under OEB.
It's IUI, I believe, is what is currently covered.
Yeah, IUI and the
Under.
medication is covered, but not the IVF.
Up to a limit per person. Right?
Yes.
Like 15,000 or something like that. We did that like 10 years ago, or not 10, 6 years ago.
Yeah, it's 35,000 right now.
Okay.
And but yeah, IVF is not covered under OEB, but it is covered under PEB with the benefit maximum.
So Kindbody would merge that benefit and the additional benefits all into one kind of thing, right?
Correct.
Got it. Other board members, do you have questions, especially our OEB people? PEB, if you have comments on how you got to this point, that would be nice. Enrique, come on in, say something, say what's on your mind.
Yes, thank you. I appreciate the conversation. I guess I really appreciate what you just asked, Bill. If the PEP members or the staff could help understand us. I'm assuming number one is the cost on why OEB doesn't have IVF. I mean, I believe, I'm a firm believer that we should give access to our members on that perspective, but I just want to hear the thoughts.
Well, I can answer your question, Enrique, about why it's not currently covered. It's been proposed multiple times to the OEB board to cover IVF for OEB, and it's always been turned down due to the cost impact.
Yeah, I think Enrique, the way it was approved to be implemented with PEB is probably 2 years ago, maybe 3 years ago. There was the renewal was below 3.4%, and they had the opportunity to add the benefit at that time. They haven't been at that point below 3.4%, I think, since then, just like OEB, but that was the opportunity to look at adding a benefit. And I think before, correct me if I'm wrong, Glenn, that OEB always had a little bit better infertility coverage than PEB, and again, that opportunity afforded PEB to make that change and add that benefit.
That's actually correct. OEB went out, or instituted early, covering medication or IUI, and SEOW even proposed as part of the fertility benefit the coverage of IVF, but due to the cost, the OEB board said, okay, we'll cover everything up to IUI. But at the initial time when the fertility benefits were installed, yeah, it was better than PEBs, slightly, but then PEB, as you pointed out, Ali, they instituted all the different fertility benefits from, counseling and diagnosis up to IVF.
Right, Robert, then Andrew.
Thanks. Just a clarification question. I may have missed it. So the PEB benefit, is that lifetime or is that cycle?
So they have both actually. So through Kindbody, through MODA, I believe it's the annual maximum on medical and unlimited pharmacy benefit. Through Providence's partner Progeny, it's a smart cycle approach, where there aren't dollar limits. It's just the cycle that is covered. And so it's a 1+1 smart cycle model, which means that each year members have an opportunity for essentially 2 cycles. If the first one is unsuccessful, you can move forward with the second cycle in that same year, as opposed to having to wait for the next year to start again, which creates a lot of issues for folks. So bit of both.
Andrew, you had a comment. You had your hand up. Did you want to add something else?
Yeah, I wanted to, let me lower my hand before I forget. I wanted to also comment on PEB's staged approach. And so these point solutions, Progeny and Kindbody, actually were implemented after the fertility benefit was already enhanced. And so PEB approved the enhancement of the fertility benefit and then later looked at adding Progeny and Kindbody. And through sort of that order of operations, it was a cost reduction to introduce Kindbody and Progeny. So I just wanted to call that out, and that's largely due to the enhanced navigation that's offered to members, which leads to better clinical outcomes. And so I know, just sort of anecdotally from talking to some friends that I know who've gone through this process through their employer health plans, like they felt like they really had to become experts in this area, right? Like most folks, they end up spending a lot of money out of pocket, even if their employer offers a benefit. And so they end up becoming pharmacy experts as well as sort of medical experts through their own due diligence to cover their own services. And so both of these vendors, Progeny and Kindbody, really, the member experience is a big deal. And sort of having someone who's an expert who sort of holds your hand and helps you navigate what is a complicated area of care is a better member experience. It's also better clinical outcomes, and it's also reduced cost. And so just wanted to share sort of PEB's history and their journey.
I'll just ask actuarially as we go through this in OEB, is it strong data or fresh data that we're speculating cost-wise on the actuarial estimates?
Bill, the cost impact, let's speak to maybe MODA's cost impact. The cost impact will be a little bit in flux now for the next few months, because that's dependent on what benefit design we hone in on with the OEB board, what sort of multi-year phase-in approach we think about, the results of negotiations that they would have with Kindbody, the expected number of OEB members that might use the benefit, especially considering that we haven't had any. So it's going to be a projection of expected costs based on our best estimates of all of those different assumptions that I just
And that
mentioned.
was the point of my question. And knowing that, is there strong data behind your estimates, or is it fresh and we're just kind of like GLP-1 where we're just kind of making a reasonable estimate, right?
Yeah, even when it's an estimate, the carriers and the Mercer team, we do our best to use actual known data to inform the assumptions, and the assumptions aren't all the same. Some of them we're more certain about than others, but we don't bring things forward to you if we don't have some confidence that they're going to be, reasonably accurate.
I'll be honest, where my head is at is that if something like this, which really benefits our members, but throws the vendor into a higher than 3.4% expense, I don't think they should be penalized, right, for that, right? That's what I'm thinking about, right? Just so you know, right?
Yeah,
Okay.
I can appreciate that, Bill.
Right. All right, let's move on.
Okay, good discussion. So let's transition to menopause support. And just for backdrop, this has become sort of a high priority topic broadly across multiple employer groups as well as across the whole landscape. So what we're talking about here is the intention to specifically support the individuals and navigate their personal journey through perimenopausal and menopausal phases. And that can be inclusive of resources to assist with lifestyle changes that take place or should take place, medical treatment, as mentioned before, potentially hormone replacement therapy, supplements, and other treatments for physiological changes due to menopause. And as well, strategies for managing emotional and psychological aspects of the transition. So basically a more of a holistic set of support. Now, some of these services, right, are sort of currently available through different programs in place. What we're talking about here is more of a bespoke, focused, targeted set of programs addressing potentially similar topics, but in context of the women's experience and their journey through perimenopausal and menopause. So that's kind of what we're addressing here. And align with the goals of both OEB and PEB. It is about equitable access to affordable care, specific to their needs in an empathetic way, but as well broadly the member education and self-care and self-advocacy that would be a byproduct of this.
Let me just throw a comment to kind of in Glenn's direction, but I assume we have one of our eyes looking at Rep. Courtney Neron's bill that kind of addresses this at the same time we're talking about this, right?
Yes.
Okay.
Actually, both these items, the IVF and the menopause, have legislation related to them.
Yep. I'm aware because I brought it up in her town hall and she got all, I didn't know she had that bill, so she got really excited. So I was like, oh, okay.
Okay, next slide. So in terms of the programs that may be pertinent for consideration within the plan design, both PEB and OEB are in consideration mode here. And broadly, it's kind of in these four categories. Within the medical carrier itself, right? How do we make sure that at the provider directory can be informative for the members from entities and agencies seeking care specifically to address their health needs and symptom management as well as health risk, that they can get to the right provider. Now, you may be surprised that, again, we have designations for specialists, but even within specialties, this is a unique area, and not all providers are equal in both the competency and training and scope of services. So that's why this is potentially very helpful for the member. From a PBM perspective, pharmacy benefit manager, things to consider would be the inclusion of and the various coverage policy around medication needs, specifically hormone replacement therapy, ability to address potential side effects of hormone therapy. Again, holistic, member-centric set of coverage and services. The behavioral health component is also equally important. Again, it's common behavioral health needs, but when it's contextualized to the unique experience and journey of the individual experiencing perimenopause and menopausal symptoms, that needs to be sort of a somewhat bespoke and tailored for that. Other things consider that would be useful, again, would be very specific nutrition support and counseling tailored to this phase of the individual's life journey.
Sorry,
Any
Andrea.
comments?
Andrea, could pause for a second. I saw Andrea her hand flash, and then it went away.
That you couldn't tell if it had gone up or not. So I was wondering, so some of the things that I see with the offer the group education for managers and employees, but I think that a huge part of the support is being able to have a doctor write something to my employer to say that there's some things that I may need because of this transition in my life. And so I think, anyway, I think that's a big one too, is that understanding, but be able to support people in the workplace by putting in plans that aid them in the physical and mental issues they're facing.
HEPA doesn't interfere with that concept?
I mean, like having like getting a note from your doctor that says I need to take a break, or I may
so it's
have
your
to.
choice. So it's not a HEPA thing because you're making that
Yeah,
choice.
no, they can't like bypass you and be like, oh, this person's going to do this. I mean, like with permission, but like giving it so that you have a reason to go take an extra break.
Okay, understood. Kimberly.
Well, and there could be the needs for some sort of fan or air conditioning or something. I just wanted to comment that, and I think it was brought up before, this is really important for women that it impacts major. There are many women that aren't impacted, but the women that do have significant menopause, whatever, whether it's hot flashes, mood, excessive weight gain, whatever it may be, I think this is worth us addressing. And I'm hoping we don't get hung up on numbers, like if it's a very small piece of our population of our employees, that's small people, that group may be very impacted. It may impact their whole world. So again, I just thank you. And I think it was brought up by somebody else about how important this is. And that's really all that I wanted to say. Thank you.
No, great points. And thank you for that. And leading to the next slide, we did sort of identify. So Andrea, your proposal is sort of a reactive approach for employers to accommodate, but the potential is for either at the agency level or entities to be proactive and to have this in place, facilitative, accommodating, but equally important, create that community and environment, the supportive, even if you're not going through that, or you're the other gender like myself that will never have that lived experience. Just being sensitive and aware, informed can go a long way. So clearly there's opportunities here. Obviously, this is also outside the health plan benefit, but clearly for the entities and agencies that we serve, anything they can do to factor this in is hugely impactful. Agreed. Okay. Other thoughts and comment before we kind of take a look at the vendors?
It kind of seems to me more legislative than what we do with insurance coverage.
Yeah.
I wonder what Courtney would say to that slide. She'd probably be really excited about. Yes.
Could someone give an overview of her bills?
Not me at the moment. I read it like a month ago.
Yeah, I can tell you the one we're watching currently at this time, which is to provide menopause support and treatments, and from the health plan level. that it be a required benefit for all health plans. And she does have a number of others related, but not, one about establishing a task force in regards to this type of support for this, and also for other kind of, parents, parent related. But I don't have the information on all the others, but this is the one we're watching that would impact PEB and OEB. Andrea, I can get you a further kind of rundown on all of her bills.
That would be
if you want.
fantastic. Thank you. Yeah.
Okay, thank you. Let's take a look at sort of the vendors being proposed in partnership with the carriers here, specifically Providence and MODA. For Kaiser, they have built this capabilities and programs within their delivery system. Keep in mind, this is sort of a summary of the vendors by capabilities out of the box, right? So it's oversimplification, and then keep in mind that the carriers like MODA and Providence basically layer on top, and they start to address some of the coordination, the network integration, and things like that. So just keep in mind, this is sort of a vendor provided sort of summarization of their core capabilities as listed on the side there. So we cover care coordination, telemedicine, and telehealth provides that convenience and access, especially when we have rural and urban areas, so that we can get the right qualified resources who need it. Helping with network navigation, again, not everyone is skilled, even though they have an MD or MP behind their name for providing guidance and clinical care around this. Coaching, medication management is obviously key and important, as well as mental health support. And then the last four are sort of some of the surrounding capabilities that really help that member's sense of community, empathy, journey collectively, as both experience and resources and tools. So again, this is an abridged version. Like I said, what will get deployed ends up being an integrated model with the carriers. Questions about this summary view?
I could just make a quick comment. We did get a little bit of clarity from Providence that the way that their program is structured is through Progeny, and then Progeny has network partners like Genev, for example, being one. And so I just wanted to provide that clarity. And they did also comment that there are some enhancements in place so that those X's actually should be check marks now. And so as we move forward, we'll make sure to get that updated, but I just wanted to clarify that for all participants today.
Robert?
Thanks. I may have missed this, but the last row, menopause offered standalone, the question mark for Kindbody. What does that actually mean?
Yeah, maybe I'm bringing confusion into that. Like I said, this is sort of the out of the box from the vendor's perspective. These vendors are being proposed through the carriers, so there's that layering on top. So outside of OEB and PEB, employers can go directly to Kindbody or through Progeny, and then Progeny will, through partnership, provide the menopause as a standalone. Kindbody, you only get menopausal offering if you purchase their fertility program.
That's clear. Thanks. I must have missed that.
Okay. Let's go to the next section, which is covering our strategy around optimizing and improving sort of the cancer screening and prevention strategy. The one we're going to cover is around skin cancer, and I have two slides to kind of frame the opportunity. So consistent with the Bill's effort to think about innovation and how do we support the individual more holistically. I'm tabling this just for consideration, and I've spoken to Teresa Cross as a means to create awareness and bring this to the attention of both at the entity and agency level. But obviously, skin cancer screening, there's a component that requires physicians to take a look at a mole and decide if there's some suggestion that this may be potentially cancerous. But until that point, the individual can do a lot, and in terms of looking at moles, tracking it for changes, what we call the ABCDE indicators of change, and then obviously seek medical review care. So up to that point, it is a visual process. It requires individuals to be aware that this is something they can do for themselves, or potentially take advantage of our carriers or programs outside of carriers to assist our members. So obviously, there are resources, and Kaiser provides that through their system and through their patient portal. MODA is supporting self-examination, self-tracking of moles through their providers. For the individual, that is self-advocating and sort of proactive. Something to think about that's within your own backyard is the OHSU Mole Mapper app, right? So conceivably think about somebody just having this app on their phone and being able to take an image, have it securely protected, privacy, but then over time they can sort of compare and contrast. And then if there's a concern, if they're within the OHSU network, they can basically set up a virtual e-visit consult, and they have that information right there. So none of this replaces the physician evaluation, but it just supports the individual that is tracking their own moles and skin lesions. The second proposal, which is within the renewal consideration, next slide, is via a third-party service called skin.io. It's an option through MODA, and it's really about similarly recording this a mole, tracking it over time, but that is surrounded with an imaging processing capability, AI, as well as access to a virtual consult with a dermatologist. So this is about improving the access, because dermatologist access is somewhat constrained, and not just within Oregon, but nationally. So having that right information in a format that can be leveraged and communicated with a dermatologist, qualified dermatologist, for them to evaluate and make potentially treatment recommendations. Some considerations here, obviously, AI, as pervasive as it is in any conversation, is still relatively new. So, some cautionary advice. We don't understand fully what that means within Skin.io. And there's nuances like different skin tones, race ethnicity, variants, and all that should be considered and cautiously contemplated. Similarly, Skin.io potentially may have dermatology availability limitations, because broadly there are limitations. So they may be subjective to some of the same constraint. That would have to be sort of factored in as we consider this within the new renewal discussion as well. So the goal is between the two, we kind of have a more holistic set of resources for individuals, for them to do their own self skin examination and tracking with a component here for a subset of the population through MODA that would basically have access to virtual dermatology evaluation and care. So the question posed, next slide.
Robert's up, actually.
Let's have a question. Since this is already in place for PEB, could somebody from PEB, talk about their experience with this this vendor?
So to clarify, sorry, the three boxes there is the key. Specifically, this is for OEB consideration only currently.
Right. It's already in place for PEP, so I was just wondering what their
No,
experience
that would be a
was.
diamond. The diamond
Oh,
is
God dang it.
represents already
Okay,
in place.
that's a key. No, okay, sorry. Yeah, stupid me.
No. It
This
took me
is
a while to figure out what
Kimberly.
that index was. Right.
If you go back a slide, I am a skin cancer survivor, and so I'm very much into routine skincare. If there's a skin cancer type, I've had them. I did use the OHSU mole mapper, and I'm not going to even, I don't have MODA, so I don't know if for some reasons it was at a PEB board meeting that somebody talked about what's out there. And because I'm one of those people that I go to the board meeting and then next thing I know, I got the app on my phone and I'm trying it out for PEB. I did use the OHSU mole mapper and it wasn't that difficult. All of them require you to actually be responsible for yourself, whether you do self-exam, whether you actually call a dermatologist, or whether you do one of these digital options. But I did find it helpful. So that's just all that I know about what we just spoke about here. Skin cancer, it's very important. It can take a person out. It can't be ignored. So
Did you need a selfie stick to use Mole Mapper? How'd you do your back? I'm trying to figure out how to twist my arm to take a picture of my back.
you need to get a helper. You need to have a helper.
Valid question. Yeah, it assists with one of the challenges is describing how your mole has changed, right? Until you have an image and you can do a side by side, it is, well, the edges are different, or it's larger. Well, how much larger? This much larger, right? So it's the assistance with capturing information so that your provider can have a context as to why you're asking for a skin examination. Okay. Moving on. The last renewal proposal for consideration was around site of care. Next slide. And the site of care is about sort of optimizing when all things are being equal, meaning quality, access, convenience, and all those other things. And the only thing that's different is potentially a lower cost of service and hence a better value. How do we inject that into sort of the clinical decision-making on utilization? So what is being proposed in the renewal by MODA for OAB, which is already in place for PED, so it's just a consideration for OAB, is the capabilities through EVCore. So again, it's a third-party service and database that is going to basically incorporate into an existing utilization management process. So for the member, it's not a thing that they need to initiate or go to. As they're getting their targeted procedures reviewed under utilization management, part of that process and conversation and dialogue is information, guidance for consideration of a redirect to a lower cost facility that should be equally convenient and accessible. The target procedures we're talking about is around advanced imaging and selective musculoskeletal procedures. Both of these are somewhat routine and, for lack of a better term, commoditized in the sense that it's probably the same MRI machine done at the hospital versus another center. So the only difference is the contracted, negotiated cost. So in that context, again, same convenience, no difference in quality and outcomes. This is something that becomes an opportunity. We are cognizant that the distribution and access is not equal. So MODA is excluding Eastern Oregon hospital outpatient departments because just the alternatives is not realistic from a convenience, accessibility, and other factors. And I believe this is a similar model that's already in place at PEB. So we're just kind of replicating that over to the OEB.
In the PEB world, how does the member know what a targeted facility, when this is going to come into play, right, is what I'm asking, right? I get an order from my doctor to go get an MRI, right? And they say, here's your place. How do I know to check this?
Can I jump in and answer that one, Dr. Trink?
Yeah, sure.
So when this was implemented by PEB 1125, so very recent, when it was being considered, there was already a prior authorization in place for the service itself. And so if you had an advanced imaging or musculoskeletal, there was already PA in place for the service itself. And so when this additional PA around site of care was essentially added for those same services, the doctor is submitting one request, and then EviCore and MODA are evaluating both PAs. So they'll first evaluate, is the service appropriate? And then they'll evaluate, is the site of care appropriate? And so that makes it easier for the providers. They're not having to submit two requests. And so, for that reason, we sort of figured it would not be something that was driving member noise. And granted, this was a 1125 go live for this benefit, so we don't have a lot of on the ground experience to report back. But the provider doesn't have to do anything additional compared to what they're doing today. And so MODA or maybe perhaps EviCore will then get back with the provider with the results of that PA evaluation. So my understanding is the member is sort of taken out of it.
Okay, so that goes with the member have an option to override?
Yeah.
Don't know the answer to that. I don't think so.
Okay.
In this
Robert?
benefit, if the member's provider, I think the key to this benefit is that if the member's provider has admitting authority at the preferred hospital, it's kind of invisible to the member because they're having continuity with their provider. If the provider does not have admitting rights to the recommended hospital, then the member would just see the same provider at the original hospital that the provider wanted to go to. If the member had a strong preference for facility for some reason, I imagine it would go through the normal exception process, and then we would review that.
Okay. Robert.
For OEB, I know, a few years ago, the innovation work group was working on the concept of centers of excellence. I'm just wondering, is this a replacement for this, or how does that mesh with that plan?
That plan was for surgery, right? If I remember correctly, hip, knee kind of replacements was targeted at that for a first round.
Well,
Margaret?
That's how
Yeah.
that's how I'm reading the slide, because it says MSK procedures is covered, not just
Oh, I
imaging.
see.
That's why I asked the question.
I was thinking that was on imaging, but now I get your point. I misread that. Right. Okay. Margaret?
Yeah, so just to chime in with some further context. So this is separate from Centers of Excellence. The Centers of Excellence program that the Innovation Work Group has been looking at is more specific around identifying best-in-class facility providers and physicians for joint surgeries. That specific program is, I think, it's certainly something I think that is there's still some data analysis and review going on with the Innovation Work Group. And I think we're going to continue to look at that in the coming, couple of years. It is certainly on a longer time horizon. This site of care program is something I think more specifically MODA is proposing in the short term for the next renewal. And certainly, I don't know if Kirsten, if you want to chime in with any other specific thoughts around the current site of care offering on the table. It is distinct from centers of excellence more comprehensively.
Yeah, thanks, Margaret. I was really happy that you wanted to chime in and give the update from IWG. We think this is a really great low impact short-term recommendation, exactly as you said, Margaret, that really considers the different geographic needs of our members, whether they're located in rural Oregon with a lot of choice of facility or Eastern Oregon without a lot of choice. And that was some of the challenge that the innovation work group work was and is going through.
Can I just add
Go ahead. Go ahead, Erica.
to this? Yeah. The one thing that I just want to also make sure to point out is that the steerage, especially for the advanced imaging, has a real impact to members as well, because it will save members money as well, especially for members who are on a high deductible health plan or who need to meet their deductible first. And currently, we have a program in place that voluntarily steers members towards lower cost advanced imaging locations. But the trouble with that is the timing. And as I think Andrew pointed out, this happens right at the PA. The voluntary program that we're doing right now happens after the PA. So it's very difficult for members after something's already been scheduled to then get to them, tell them about their options, and then for them to switch. So this will have a real impact on members as well as the plan.
Understood. That was the point of my first question, was how does this get integrated into the members? Okay. Anybody else?
Just
so this is in the first
clinically-
round renewal. This will be in our first round renewal for OWEB, right?
Bill, it's not part of the presentation in this afternoon's discussion, but then once the SEOW committee has an opportunity to make a formal
see.
recommendation next month,
Then
that
we
will
could
flow
add
through in
second
March.
round, maybe
Yeah.
second round. Okay. Yeah, I just say be wary of our border members who are along the border, where sometimes it's much easier to access across the state line than it is within the state. We have that situation, but you've already eliminated that with Eastern Oregon being out of the context. I assume that includes Hermiston all the way around to Ontario when you say Eastern Oregon, right? Okay.
That's correct.
And just to clarify, with the advanced imaging, like I said, I think the procedure ends up being the same. It could be even the same device, right? By Siemens. It's just doing it at A or B.
Yeah, it's scheduling. I know even here where I live in the valley, scheduling at different places is quite different. Uh-oh, did Ian freeze on us? I see everybody moving but Ian. Oh, there he is. He's back.
There.
He's back.
I think this was the last on this section. So if there's
Okay.
any wrap-up questions or thoughts?
Are we when Kirsten, sorry, when do you need SEOW to decide this should be in the second round? What's the timing?
So we're sorry. So we're thinking that SEOW next month would begin to deliberate. And just like last year, if the SEOW committee is ready to make a vote on an initiative, maybe because it's more straightforward, I think it'd be appropriate to do that in next month's March SEOW committee, and it could come forward to the board. There are some things that may take a little bit more time, and we'd be bringing those forward in April. But next month, if they're ready, they could go to the board.
Okay, that'll meet your bidding constraints, whatever the renewal constraints, right? As in,
that's right.
This is one of these new situations where PEB already has this, so only the OEB members are actually making a recommendation, right? But we're all here. Okay, got you. Thanks. Vendor partner performance review.
All right, it's me again. Thanks, Bill. All right, so if we can move to the next slide. So I'm going to talk now about our vendor performance review project. And back in December, Dr. Twang had shared an overview of this project. And really, the role of these vendor partner solutions is to offer services, and particularly oftentimes they are focused on a specific condition or need, and they're supplementing what the carrier offers, and oftentimes might fill a gap in care, maybe offer wider availability of the services to the population. And so this is just kind of capturing what some of the roles can be and some of the specific health concerns that these partner solutions that are in place address. As we move to the next slide, we do have, so there are a wide range of these vendor partner programs in place. This is capturing OEB and PEB all together in these different categories. Behavioral health is starred because that is the focus area that we're going to be looking at first. And so for today's conversation, I'm just laying some foundations, sharing the kind of assessment evaluation process that we're going through. And later on, I'm also going to share a little bit more about each of these behavioral health vendors to really set the stage for our conversation next month, where we'll be actually showing the data and the assessment that we've been going through. And so again, just wanted to share, this kind of gives you that breadth of services that are available as vendor partner programs. And we will be looking at these other ones in a cadence in the future. Again, made a lot of sense to look at behavioral health at this point for the renewal process this year. All right, if we move to the next slide, please. A question, just curious, did you all know about all of the partner vendors that are available to PEB and OEB members?
Team?
I see Kimberly nodding her head. That's great.
It's a yes for me because we went through a lot of these last year.
We
right?
have.
We went through
Yeah.
a pile of them. Some of them I was not aware of, but I definitely was aware of most of them.
Great. Awesome. All right. And so earlier, Andrew showed part of this slide that really does show this wonderful alignment between PEB and OEB values and goals. And we wanted to then also share, kind of why this vendor program review is kind of coming forward is because it also fits really well within the shared values of PEB and OEB. And so, really again, that these vendor partners are supplementing benefits and services, closing gaps in care, oftentimes offering a very high quality vendor because they have a specialty focus in that one area. And we kind of saw that with menopause. As Dr. Twang had shared, there's some knowledge within providers, but there is definitely a gap or some insufficiency as far as being as up to date. And so oftentimes these vendor partners, that's their focus area, and they can really have that specialty. It also helps oftentimes with affordability, reducing member out-of-pocket costs, and then also sometimes, providing access to these cares and service, again, at a much lower cost. And then really these vendor partners do improve member education and the member experience. I think, Andrew, you also gave a great example of this previous when we were talking about Kind Body and Progeny and how they really do enhance that member experience and the education around fertility treatments and helping that member navigate. So just, again, super alignment with the PEB and OEB values. So let's move to the next slide, please. And, as we are looking at evaluating these vendor partners, this is the framework we're using. It probably looks familiar to you because this also is really the framework we use for our clinical strategy. And so on the left side here of the slide first, selecting what we're looking at, we chose behavioral health because it made sense as part of this time in the renewal process. There's a lot of vendors in that space as well. The star is showing right now we are in this assessment and evaluation. We've requested lots of data from the carriers. We appreciate them taking the time because it was a lot of data that we've requested, so much appreciation on that. So we've requested this data and we're in the process of assessing, putting it into a format that we'll be able to share with all of you next month. As part of this assessment then, if I move to the right side here of the slide, in these assessment categories, you can see we kind of have 4 key categories. So we're going to be looking at engagement and utilization. We'll look at the member experience, equity, and then the outcomes and measurements components. The next column showing those key metrics is just showing, some of the different metrics that we've asked for. These metrics will vary by the different solutions because some of them aren't necessarily delivering care, so they might not have appointment times and things like that, but they are more of a navigation or maybe a meditation, mindfulness kind of program. So, but we do have these key metrics so that we will be able to show the data in a way that makes sense and can provide some steps to the next part of the evaluation approach, which is taking action. And so these assessment findings, our discussion with you next month, will allow us then to really determine what the actions, the recommended actions would be. I don't know if I have a prompt slide, but I'm going to just pause to see if anybody has questions. Oh, good. Yes, we do have a prompt slide.
Taking joy in no thrills to get a vaccination.
So did those areas, I guess, that we captured on that previous slide for evaluation kind of meet the areas, or I just want to make sure, does anybody have input, anything that we're not capturing or that you feel is really important for us to make sure that we are using in our assessment evaluation?
I don't know if it covers every one of the vendors, but like length of time that the participation lasts. Like, did you sign up, come to 3 months worth of meetings and then fall off, right? What's the longevity of the member engagement? Is that there somewhere and I'm just not seeing it?
We have it. I might not have just put it on here, but it depending on the solution, you're right. Like we might have, for example, average number of sessions attended. Yes, that's a great one, Bill.
That's the only one that pops in my head.
It definitely comes into play for outcomes because again, if we're tracking a biometric, it's not just that they hit it once, it's are they able to achieve it and then maintain it over time? So persistence is going to be important, and that requires us to understand their duration of engagement.
Duration, that's the word I couldn't think of.
Yeah, that's great. Thanks for that.
Alrighty.
Okay.
Anybody else?
I'll move.
Yep. Okay, we're good.
All right, let's move on. And so, okay, so now, I wanted to look a little bit closer now at behavioral health. And so again, this foundational information is really for you about the behavioral health vendor partners that are in place. And so again, so you have this information top of mind for next month when we really are looking at the data and can kind of use it as a guide. So this is really the behavioral health ecosystem right now for OEB and PEB. Just to orient you to the slides, on the left-hand side is kind of what we've called our core programs. Part of this vendor performance review is we did not dive into the exact programs that like Kaiser, Moda, Providence offer as far as like behavioral health case management, or that is done separately. This is more of a focus on those vendor partners that our core programs have subcontracted with. I'm just going to say one exception is the EAP, which is the last one on this list, which is Canopy. we will be incorporating some of their basic EAP service information into the data that we share next month. So Kaiser is a core program. They have vendor partners, Calm and Headspace. Moda Health has a couple programs you can see here, and I'm going to go through all of these in detail. We have dots around the ones, or the dash, the blue dash around Moda Behavioral Health Champions, Gemini, and Hazelden Betty Ford. Those are only an OEB program at this time. And then Providence has programs that have the green dash around them, and those are obviously only for PEB, since Providence is with PEB. And then one other thing I just wanted to call out on the ecosystem is Whole Life Directions is a program right now in place with Canopy. It is a sort of a digital cognitive behavioral therapy program focused on emotional well-being. And this vendor partner they have is changing in the future. So next plan year is our understanding.
For those, Canopy is our EAP vendor, right? Is that the same for PEB?
Correct. Yes. So PEB has had Canopy in place, and I'm sorry, I'm not sure when that relationship started,
yeah.
but I think it's been several years. And then Canopy is the new EAP for OEB that just went into place 10/1 of 24. All right, let's move to the next slide, please. All right, so I know there's lots of words on these, so I'm just going to give a high level, but again, this is to be sort of used as a guide. So as we're talking about the data and seeing the different components of the programs next month, you have it. So again, Kaiser has Calm. It might be an app that people are familiar with. It offers stress reduction, sleep, cognitive, like cognitive behavioral therapy, sleep components to it, as well as mindfulness. They do obviously have a direct-to-consumer product. It is offered in 7 languages. There is also Headspace. Headspace is an interesting vendor. They've been in the market. They started as a mindfulness meditation vendor, actually in the UK, and since have made lots of acquisitions and have now grown to a full behavioral health offering. They do have through Kaiser's contract, they have stress reduction. They have the same kind of like a sleep component, mindfulness. They also have behavioral health coaching, and then they also have direct therapy services, all provided virtually. One thing about Headspace that's interesting is they, through one of their acquisitions of Ginger, they have specific care and support for adolescents ages 13 to 17, and they're available in 5 languages. For Moda, so Moda has a component of they have a behavioral health offering that's called Behavioral Health 360. Under that offering, there are a navigation that is a Moda program, which is called BH360 Champions. And then they also have these vendor partners. This is an area that there are some differences between PEB and OEB. OEB has in place the full BH360 program, which includes the champions and all of the vendor partners. PEB has in place Spring Health and Maru Health. So I just want to make sure that that distinction is, that I'm clear about that. So the BH360 champions are offering navigation. They help members that call in find providers that match their needs, and they do provider verification for availability. And then they also have follow-up with members to make sure it's a good fit, that they made their appointment, and to see if any additional resources are needed. Spring Health as a vendor partner is really, I would say, one of our, it's a, what I want to say, innovative vendor that has really changed the market in the last 7 to 8 years. They are set up as like what we call a client-specific network that enhances the Moda Behavioral Health Network. They do have navigation through care navigators. They have self-guided resources around sleep mindfulness. They also have behavioral health coaching, and then they provide therapy, licensed therapists, and then also have psychiatry and medication management. One of the things about Spring that is a differentiator for them is that they do have all of their providers have to make their schedules available online for real-time scheduling. They have pictures of their providers and their bios. They have a pretty good diversity makeup of their provider network. And they also have great supports in place for their providers, offering they all are on an integrated health record, and then they have supervision and all sorts of components for their provider network. Maru Health, a 12-week program that is aimed specifically to treat anxiety, stress, depression, and burnout. It does have a dedicated therapist. It also has some peer-guided, peer community and self-guided practices. Interesting enough, sorry, I should go back. Spring Health has many languages available. Just want to make sure that I'm clear with that. I think the last I knew was maybe 22 languages, I think is what Spring Health has. Maru Health has English currently available, Finnish, and then Spanish is on their roadmap. One interesting thing about Maru Health I just wanted to share is they do have a biofeedback device that is incorporated into a members program so that they can get this biofeedback device, practice a breathing exercise, and be able to experience right there that by deep breathing mindfulness that their kind of regulation can change, and they can learn how to develop that skill set. Gemini is a resource-based program with discrete video modeling that supports children with autism spectrum disorder and other developmental disorders. They do have some parent coaching and resources available. And then Hazelden Betty Ford is a pretty well-known substance use disorder facilities. This particular offering is resources and self-screening that somebody can go on and learn more about substance use, do a self-screening, and then there is a call to action in either on the, they can do a call to action to a MODA behavioral health champion, or there's also the phone number there for the Hazelden Betty Ford assistance. Any questions on these before I move to the next page? Awesome. All right. So then under Providence, they have a behavioral health concierge program. My understanding is it has similar navigation components, so there's a consultation service available. This one does have licensed behavioral health professionals that are answering the phone, and they do provide kind of that in the moment counseling support. And then some offering that kind of that same day, again, calling in, feeling in crisis and getting somebody to talk to and help me navigate how I'm feeling, do an assessment, and then connecting me with care. Providence also has a contract with Talkspace, so virtual counseling, therapy, medication management. This is for ages 13 and up. And they do have self-guided exercises and resources for people to also do on their own, and they have 32 languages offered. And then Charlie Health is an intensive outpatient program. So oftentimes IOP is kind of that in between, more than outpatient, going to see my therapist once a week, but not quite inpatient, where I'm, going in, staying somewhere. So virtual intensive outpatient, it is for teens and adults. They do have connection with a primary therapist. They also have peer support, which is really a big component of IOP. And then they also offer resources for family members. It is ages 11 plus. One interesting thing I just wanted to share about Charlie Health is that they do have a really wide variety of therapy modalities that they're using so that they are able to also treat anxiety, depression, but also suicidal ideation. They have dialectal behavioral therapy, which is another, that's an evidence-based approach for suicidal ideation. And they actually incorporate art and music therapy into their offerings as well, which I thought was interesting. And then lastly, to talk about Canopy, who is, again, the EAP provider. So we have our EAP services. Oftentimes, EAP is self-guided resources. It's also navigation, in the moment support. And the services offered for OEB, again, just started in 10/1 of 24. It's an 8-session model for counseling and or coaching. And this is an 8-session model per life event. So if somebody has, one of my examples is if somebody is going through a divorce maybe in February, they can have 8 counseling sessions for that. And then let's say maybe later on in August, they're noticing their teenager and they're having a hard time with that relationship. And so then they can get 8 sessions also for that event. PEB has in place a variety of session models that are offered to the agencies, a 3 to 8 session model. 2 of the vendor partner programs that we're looking at with Canopy is Whole Life Directions, which, as I said, is that digital cognitive behavioral health program. It's all app-based, self-guided. Somebody can take a wellness survey and they get personalized recommendations on their goals and kind of treatment plan of what to do. And then Together All is a peer support program. This is a new vendor as of, I think it was June 1st of 2024. We did do a health equity review of Together All, and this is really an anonymous virtual space for members to share their experiences, 16 years and up. This vendor, and I think part of the reason Canopy put them in place is that it does have a moderator that they call wall guides that are moderating this, and it's text-based, which is why it's in English only, but they're moderating kind of this text-based peer support that's going on so that they can pause accounts, they can do outreach if anybody's indicating high risk. And so we'll have some data for them as well. All right, next slide, I think, is a prompt slide just to ask you all. Any questions? Or is anybody surprised by all of the services offered?
I think just trying to get staff to realize that they have so many things offered to them. I think it's easier to just say, I have no options, than it is to actually do a little work and find somebody that fits your needs, right? In person, on screen, digital.
Yeah, that's a great point. And I think too, when somebody's in crisis, it's so hard to then go back and figure out, who do I call? Where do I go? But yeah, there's a lot.
Is there details on teen access to do they have to go through the member, or what's the pathway for a teen here? I saw 2 things that specifically called out teens.
That's a great question, Bill. I know some of them off the top of my head. So for example, the Canopy EAP, if a teen were to call in and they use the state requirement of age, then they can initiate services. Oftentimes they might ask for the teen to incorporate their parent, but they can initiate services, I think, through the EAP on their own. Headspace, my understanding is that its access is granted through the member for that teen to be able to access those services. But I certainly I can provide a much more in-depth layout of how teens can access services and kind of what those guidelines are that are in place.
I think for this kind of thing, it's kind of an equity question, because behavioral health, right? Teens having trouble maybe can't go through the member, But at the same time, they're initiating a cost for the member, right? So the member's going to find out anyways, right? This is kind of a weird situation, right? But there it is.
Yeah, and that's the value of, I guess, the EAP, right? Because then the member would not have a claim or an EOB for that visit. So
Yeah. So some kind of knowledge education on how that goes, how the member would understand that. Dr. Laura, you have your hand up?
Yeah, thank you. So this is actually great resources. I'm just wondering about cultural awareness and how each program apply that, or if they share that with us. Thank you.
thanks, Dr. Lara. That's a great question. So we did do this as a health equity group. We have looked at cultural awareness, humility in the state of Oregon to understand better, I guess, how this is looked at. So there is legislation that's requiring for each of the licensing boards to require cultural training for a licensed provider. So that would obviously pertain to like LCSWs or LPCs and other providers. Specifically for each of these vendors, we have asked these questions. And there's not a requirement for training, but we do ask and can certainly have that and provide that information as far as, are they annual trainings? Are they required? Do they keep records of like how many of their providers participate? And even their care navigators that are answering the calls, how are they trained? So we do collect that information. There's just not a lot of, I don't want to say metrics that can be compared apples to apples, I guess, amongst the vendors.
We're a little bit behind schedule. Where are you at in your presentation? I'm scrolling through your slides.
I think this was it. Yeah. This
There we
is
have
it. Yeah. So just our next steps, as I said, next month we'll be sharing the behavioral health partner data, and then you all will go through the process of making recommendations.
Making those recommendations to each board. Okay. All right. Anything else from the floor? Seeing no hands. We have a vendor management report. Oh, is that right? Oh no, that was your deal. Is that right? Hold on, I'm confused myself. That was the vendor management report, right? So we are not.
It was, Bill. Yep.
We are way ahead of schedule. Hold on. Okay, I missed the transition from section 5 to 6 somewhere. That's what Sudafed does to you, right? All right. At this point, then, let's open the floor for engagement on the board. So this meeting, we did a little differently. I'm talking to board members now. We kind of put in breaks where we could have strategic pauses where everybody could chime in on things. Kimberly, I know this is your first SEOW meeting, but did you feel like you are sufficiently chiming in? I'm asking everybody now, not just Kimberly, right? Did you get your information and discussion points were handled well? I'm talking to the board. Everybody, please make a comment.
This is Andy. I liked it. I like having those breaks. When I teach presentations, this is something I teach, is to have the factor of here's a question for the audience, because it also makes your audience pay attention. They know it's coming.
Robert, Dr. Laura, Kimberly.
Well, I'm fine with the format. I've never had a problem with being able to chime in, but the prompts are fine.
Yeah, and I've attended many SEOW, but I've never been where now I'm official. And like all of these different groups that I join, whether it's Innovation Work Group or back, 7, 8 years ago with PEB, there'll be a learning curve for me. And so I will just ask questions and I'll admit when I don't know the answer. But I did appreciate the breaks, the cued questions for thought. That all worked for me. So thank you.
Excellent. Dr. Laura, did you have a comment?
Yeah, for me, it was really enjoyable. You can say I love a lot of data and graphics, so that was great. Also, I asked a lot of questions today, maybe or comments. So that's the way I process things, and then maybe later on I'm gonna have more questions, so do a follow up maybe. So, but thank you for all this presentation and the effort you're doing. Thank you.
Glenn, did you have a comment?
Yeah, I was just wanted to make sure, and you kind of touched on it, Bill, but if especially the really presentations on the clinical proposals, as well as the vendor partner data, but are there specific items that the CL members had that they wanted follow-up information for in regards to these presentations? That way we can get the answers, and Mercer can get the answers too, and bring that back in March.
You're asking if we had any follow-ups that
Yeah.
are in memory right now?
Yeah, if there were any specific follow-up questions to those presentations that you wanted answers on before SEOW deliberates on recommendations next month.
The last presentation is what's on my mind. There's just so many choices between a member having access to mental health and also a teen getting access to mental health in a private and safe space, to wonder how you're in crisis and you're trying to make this, how to try to figure this out. That's why for OEB, I know we've liked, or at least some of us liked, the behavioral 360, because it was an entry point to say, okay, let me help you guide to the best service that we have for you for where you're at. But it's a difficult one to sit there and say I'm in crisis, and I'm in crisis again because I don't know how to get help. There's too many choices, right? Not saying that choices are bad. It's just I don't know how to choose. There's no little flow chart that says if this, then that, right? So, not saying that can be, but just that's an engineer talking here. So, yeah. AI work and mole stuff. The first thing that pops in my head is the confidentiality of taking all kinds of pictures of yourself and loading it up on an app, right? Okay. I'll have to, being an old person, settle in with that one, right? That might take me a few minutes, right? Others. Ali, you have your hand up.
Yeah, I was just going to follow up on what Glenn said. And if you have any thoughts or questions or comments that come up after the meeting and want to reach out, that we can track down before the next meeting, just please feel free to reach out.
Ali, who do we send those questions to?
Either myself or Glenn Bailey.
Okay.
Yeah. And as far as the women's health care, that's great that we're there. It's sad what Dr. Schwang said about, the medical research community is way behind on something that has been around for a long, long time. And the concept of keeping track with where our legislators are thinking and where they're driving for in conjunction with what we're doing with our plans, updates, and things. So anybody else chiming in on the today's subject matters. Those were the three primary factors, three components. All right. With that said, any public comment?
No, you don't have any public comments.
All right. Well, I'm glad we got through the material. Everything was awesome. For OWEB members, I'll see you in an hour and 15 minutes. And let's roll up and make sure we have all the things ready for decision-making recommendations for March meeting. And we'll roll from there. All right. PEP member, if you can draw straws or everybody jump and the person who jumps the furthest gets it, to join me at the leadership meeting, right? Not necessary, but up to you, right?
Was Kimberly here when we went over that?
Oh, good question. Good.
Yeah. Do you
good
want to
point.
do a recap?
Kimberly, before you joined, we talked about the things here, so that I would go ahead and finish out being the lead of SEOW for this year, because there's only three months in the June wrap-up meeting, prepping for the next year's coming along. We have a every other week SEOW leadership meeting on Mondays, and I was asking that one of the PEP members join me, because there was a suggestion that maybe, and not required, but that we consider as CL members, we flip back and forth every other year between a CL member, the chair being from PEB and then being from OEB, back and forth kind of a thing. I think that's a great idea. So, but for leadership meetings, we should probably have one person from each, the chair and from one from the other board, to be in the leadership meetings, because we're planning out the agendas for the year and then making sure that we're covering what we need. So you have a PEP meeting coming up, or however you guys want to do it, draw straws. Yeah, you gotta spend 40 minutes with me, on a Zoom call. That's horrible, but you only have 4 more months, right?
So Ali, is this the same thing that I did as PEB leadership, where we would meet and talk about the meeting coming up and kind of game plan, or?
Yeah, similar.
Yeah, same
Yeah,
thing, because
it's just for the CL, and it's basically the same thing. Talk about issues, talk about what's coming, the next month, what is our work plan, and do we want any changes?
Did any of my peers jump up or jump high, or?
I was the only one here. So without Greg, I was like not going to jump up in the air until I wasn't even sure that was something that we were like on board with everything in the RFP. So I'm just really glad that you joined us. So you can also be privy to this information.
Yeah. And I'm not involved in the medical RFP, if that makes any difference. I just, because of time limitations, I'm not currently a board chair or vice chair of PEB. I'm happy to help if you'd like me to step up and join Bill. I can do that. I don't want to step on anybody's toes. So if somebody else had their heart set to do it, I'll stay out of the game.
I'll let you guys. I'll let you guys just let me know. Talk. I'm hopeful that Greg will be able to get past 10,000 Mexican soldiers that are on the border now. So then he gets back here, and then you all we'll just settle it, right?
Ali, can we do that at our next PEB meeting?
Yeah, we can talk offline, get that figured out.
Yeah, since Greg isn't here, you can always volunteer him.
That's true. I just don't know with his schedule. I can't remember if he's days. We've just got to be careful because he's an officer. He actually has a day job.
No, I was just.
I mean, we do too, but he's actually got to be on post somewhere.
Yeah.
So.
Sounds good.
Okay, we'll let that be. All right.
Yep.
But in that case,
all right.
Dr. Schwang, you got your hand up?
Yes, just to close the loop on the earlier question about the age distribution of women in our OEP and PED population. So the categories of 18 on to 45 plus, 46 to 55 all of them are a little higher within PEP. So the distribution is the same, but the percentage prevalence is just a little higher. So just wanted to close that circle as that was a question.
Excellent. All right, seeing no more hands or inputs coming in, I will adjourn this meeting at 11:51. Thanks, everybody.
Thank you, everybody.
Thank you.